So I'm Angela Vincent. I'm Emeritus Professor of Neuroimmunology at the University of Oxford, where I've worked for over 25 years on antibodies in neurological disease. One of the many conditions which patients can develop, sometimes quite acutely, during adult life, is ataxia. And these patients are not usually expected to have a gene defect because the disease starts rather acutely, over perhaps just weeks. And antibodies is one of the things we now look for in those patients because antibodies can tell us something about the disease. So what I spoke about today is about the three sorts of antibodies that we can detect in patients. Firstly, there are those antibodies that are biomarkers, just signals of something going on in the body, which is usually a tumor. What happens then in those patients is that the patients have a tumor. It may be very small, but they begin to react against it and make antibodies to the tumor, trying to destroy the tumor. It's a natural defense mechanism of the body. Unfortunately, some of the tumors contain proteins which are similar to the proteins in the brain. So the antibodies that the patient makes against the proteins can bind to the patient's cells in the brain and cause disease. Those antibodies are important biomarkers for the presence of the tumor, but it's rather seldom that we can do anything much to improve the patients. But they're still very important to test because they tell us that the patient's got a tumor. The second biomarker is called glutamic acid decarboxylase, or GAD. And we and others have been measuring these antibodies in patients with cerebellar ataxia for many years. Only a few patients have these antibodies, but we feel sure that they are telling us that the patient has an immune-mediated disorder. That is, it's their immune system which is reacting against the brain, even though those patients don't have a cancer. We've found these antibodies in a small proportion of patients with cerebellar ataxia over the years, and we would like to make sure that those antibodies are helpful by trying to get the patients treated quickly if they have those antibodies. The reason being that if you wait too long, then the patient's cells have already been destroyed in their brain and the ataxia is probably not going to be treatable. So that's another sort of antibody. But the ones that we are perhaps now most excited about is those antibodies that are definitely causing disease. And what I showed today was some examples of patients who have antibodies to proteins that are expressed, that are present on the surface of cells in the brain. And when the patients have those antibodies, they do get into the brain and they cause changes to those cells which are resulting in various symptoms. Now, those symptoms can be very diverse. They can involve memory. They can make the patient have epileptic seizures. They may have movement disorders, and they may have ataxia. But the most striking thing about those antibodies is that when you find them, you can treat the patients by giving them therapies that reduce the level of the antibodies, and those patients very frequently get very much better and often are able to go home and live independent lives again. So those are the antibodies we're most excited about because they mean that the patient can be treated. Now, the trouble is, and what was rather sad today, was that not many of those patients have ataxia as their main problem. And therefore, knowing about those antibodies so far hasn't really made a difference yet to patients with ataxia. But what I would like to see in the future would be for much better collections of serum and cerebrospinal fluid from patients who have fairly recent onset of ataxia and are not yet too badly affected. And then we would be able to look for novel antibodies that might be causing their disease and which would then lead, one hopes, to immunotherapies, treatments for the immune system in the future.